Welcome to our event today. My name is David Armstrong, and I'm the director of the Health Workforce Technical Assistance Center. And today's webinar is jointly sponsored by Academy Health's Health Workforce Interest Group. It is entitled Career Pathways and Health Workforce Research. I am also a member of Academy Health's Health Workforce Interest Group. Full disclosure, I'm on the advisory committee. So I want to take a moment before we get started with today's show to go ahead and describe our work group a little bit with you. Our mission is to improve health and healthcare by promoting research and disseminating evidence that informs health workforce policy and practice. And joining our interest group is free as long as you're already a member of Academy Health. And if you do join our interest group, well, you can use our listserv to share information such as, for example, if you have health workforce research you think the group would be interested in, by all means, share it along the listserv. Or perhaps you have a faculty position or job opening which you think would be of interest to health workforce research. You can also pass it along via our listserv there as well. That said, if you have more questions about the Health Workforce Interest Group, you can contact our chair, Janet Coffman, or vice chair, Xiaochu Yu. And with that said, I think I'm going to go ahead and turn the event over to our moderator, Janet Coffman, who, as I've already mentioned, is the chair of the Health Workforce Interest Group. And well, amongst other activities, she also does a few other things. Specifically, she's also faculty at the University of California, San Francisco. Janet, would you like to take over at this point?
Yes. Thank you very much, David. It's a pleasure to be here with all of you today. This webinar is really a successor to virtual events that the Health Workforce Interest Groups held in 2021 and the previous year. And those were virtual events in which we had upcoming researchers, PhDs, and postdocs on the job market kind of share their research and their interests and get to talk to folks who might potentially have job openings or at least be mentors to them. And as we did those two webinars, it became clear to me, and I think to others on our advisory committee, that people have a lot of sort of general questions about health career pathways, and that there would be value to a webinar in which we invited 4 members of our advisory committee who are, at various career stages, have very different sort of educational backgrounds, so to talk about their experience, talk about their personal journeys, their career paths, and insights they've gained along the way, not only from their own experience, but from the experience of people they've mentored. And so with us today on this panel, we have Eric Apaydin, who is a PhD researcher at the VA Greater Los Angeles Healthcare System, Lorinda Coombs, who is a nurse practitioner and PhD in nursing, who's based at the University of North Carolina, Chapel Hill, is on the faculty there, and Clark Ruttinger, who is with Global Data, a healthcare consulting firm, and who until very recently spent a number of years working in Utah state government on health workforce research. And then Noelle Smith, who is with the American Academy of Physician Associates, leading their research work. So without further ado, I'm going to ask our 4 panelists to kick it off. And I think we can maybe start with you, Eric, and then pass the baton in whatever way we want to do that. And just, now that I've told folks just sort of a little bit about where you are now, maybe if you could each speak for about 3 to 4 minutes on your position, a little bit about the work that you do now and sort of your career pathway, the journey you took to get to where you are today.
Thanks for the introduction, Janet. So my name is Eric Apaydin. I'm a core investigator at the VA Greater Los Angeles Healthcare System, and I'm a newly funded career development awardee. So right now I study burnout, and I have for the past 3 or 4 years since I got this position at VA, first as a postdoc, now as an investigator researcher. And I primarily study burnout in primary care, but across professions. And I'm also looking mostly at organizational predictors or causes of burnout, and then I'm trying to investigate any sort of interventions that we can deploy organizationally to reduce it. So how did I get here? I will say the story doesn't make much sense even to me. So, in college I was pre-med, and I decided medical school wasn't something I wanted to do. So I first gravitated towards biological research. I got a master's in molecular biology, but I wasn't great at it. I wasn't good at pipetting, all day. So, and I also wanted to move towards something that was more social and organizational in its relation to health. So I decided decided to move towards policy. So I thought that PhD programs were pretty competitive, so I should get some training as a master's first. So I got a master's in public policy at Berkeley, and I learned more quantitative skills that I didn't have with my BA and MS in biology. And my research interests were not super developed at that point. I was sort of interested in obesity policies and stuff like that. But I applied to a number of PhD programs. The best one I got into was RAND's graduate school. So the RAND Corporation here in LA in Santa Monica, they have a PhD program in policy where the students both take courses and write a dissertation, of course, but also work as sort of assistant researchers for the researchers at RAND on different projects. So there, since I was a little bit still indecisive as to what topic I wanted to cover, I was able to work on a variety of things in not only in health, in different topic areas as well. So on one of these projects, I was working for some Army researchers on what enlisted personnel would do after they quit the Army. Right? I thought it was really interesting. I'd never been exposed to that sort of organizational research about the workforce before. A lot of people complain that they couldn't find good jobs, their skills in the infantry was not useful, that kind of thing. So I thought, this is great. I really like this. I don't really, not interested in military research. So how can I connect this with healthcare? So then I talked to a few more researchers. I ended up connecting with a researcher, Mark Friedberg, who no longer works at RAND, but he had a big AMA survey on physician satisfaction. So I was like, okay, so I gravitated towards that. I ended up writing my thesis or dissertation on this physician satisfaction. I also did a paper on the physician gender income gap, which is another big topic. Okay, so I did this, and I was really interested in sort of the physician work life and the work life of healthcare workers, essentially. So I thought, okay, so how after I graduate can I stay in academia and still work on this? So I thought, talk to some people. The consensus was you had to get a postdoc. Okay. So I applied to a bunch of postdocs. The best fit was VA because they were very concerned about burnout. Now, I'd never really heard about burnout prior to this. I didn't know anything about it. But VA had a big burnout problem. So that was a good fit. The postdoc was in LA. So I went to VA, and then I wrote about 7-8 papers on burnout with my mentors. And they said, okay, you're really interested in this. You could be the burnout guy for VA, but you got to win a big career development grant to be funded. So I went through that. Took me 3 tries, about 1.5 years. It was just funded. So now I will be at the VA for the next 5-6 years doing that. But, it was a long journey, and I probably could not have predicted it 15 years ago, certainly. But now I'm very interested in burnout, and I love working at the VA, and they have a wealth of data. They have national databases that I can use to analyze this. So I'm happy.
Great. Well, thank you very much, Eric. I think now maybe I'll ask Noelle to speak next.
Thank you, Janet. Hello, everyone. My name is Noelle Smith. I'm the Senior Director of PA and Industry Research and Analysis with the American Academy of Physician Associates, or AAPA. We are the professional association for the PA profession. And my pathway in health workforce research is not a traditional one. I started my career as a research assistant in undergrad, where my love was psychology. So after a year of continuing that work, post undergrad, I started a PhD program in clinical psychology. And I knew going into that program, I didn't want to be a psychologist, at least not full time, but rather I was interested in teaching and research. I did learn by the end of the second year that I would be really unhappy working in academia. It was not an environment that really meshed with who I was. So I elected to finish my master's and leave my program. When I left school, my first job was in workforce research, and that's remained the focus of my work for the past 22 years. I started by looking at the child welfare profession and also looking at population health statistics. So there was always a little bit of health there. I remember healthy people I think it was 2000 was still there when I started. I later moved to the human resources management profession. From there, I jumped over to a consultant specializing in the federal workforce. And 9 years ago, I started consulting with the AAPA. And in 2015, so just shy of 8 years now, I came on staff full time, and I've never looked back. In fact, I tell people all the time, I've discovered my love of not just workforce research, but specifically health workforce research. And each step of my career has brought me insights that I use in my current work. So with that, through this circuitous route, I've gained an understanding of population statistics, of workforce issues on the business side, and now I'm understanding more about the workforce issues on the clinician side. I've learned directly about developing a common language, so making sure that when you say burnout, for example, as Eric referred to some of his work, that we're all talking about burnout. There are nuances, whether or not, you're including things like moral injury, and understanding why those nuances are so important, because it can impact what you're directing and what conclusions you're drawing. I have learned how research can direct policy and why policy can lead research. And I've learned to talk the talk for consumers, for professionals, for the advocates, for the leaders, understanding how to tailor my content to each of them for the maximum impact. And it's something that I think for most, something that you really just learn from being boots on the ground. So in that said, in my day-to-day job, I oversee a research team of currently 4 people. We conduct primary research through surveys and focus groups. We also utilize secondary data, such as the National Provider Database, CMS data, ARC, social determinants of health data. We conduct targeted literature reviews. We develop briefings for our advocacy work, and we do so much more. And what's amazing is that there's never a dull day. It keeps you on your feet. So if you want something that includes novelty, this is association work is your way to go. So some of the things I absolutely love about the work I do is that there is a ton of variety. So there are the projects that we do because it's for our membership, such as our salary survey. There are a lot of opportunities to also study topics that we're passionate about. So like Eric, my passion is burnout, and I've been in that burnout and well-being space since 2016. And it's not just about looking at the incident rates, which is what it started as, but also how investments to support staff can yield value for the organizations, for the patients, and the clinicians. I also get to see the work I do directly impact the advocacy and policy work being done at the state and federal levels. So my work that I do truly makes a difference in the lives of patients every day. And I think that's really, really exciting. I don't have to wait 10 years for a publication to make its way to a legislator or a clinician's desk. So I can do those really fast turnaround reports. I have access to the clinicians being studied and know more about the nuances of their behaviors than probably most. And I can be nimble when questions need to be asked. So I don't have to wait for IRB. I don't have to wait for politics and paperwork to go through. I can put a survey in the field in 2 days, which I'm actually currently doing. I have also, though, created an environment where scholarly pursuits are expected. I build into my operating plan each year several peer-reviewed publications and several presentations and several conferences every year. And I consistently have a PhD level team member on my team. So when each is joined from an academic position, I've asked my team members, particularly those, the 2 that we've had that have PhDs, why are you coming to us from academia, right? They both come from an academic position. And the 2 big benefits they see are that there is no pressure for tenure, to secure funding, to publish, and politics. Like, there is no pressure. in what we do. It's really great. I'd never have to secure funding. If I get it, that's fantastic. But the organization supports us. One member of our team loved teaching. So he actually kept teaching through an agreement that we set in place. He approached us. We said, yes, we can even work around if you have a daytime meeting. Let's work with you to make sure that happens, because I know it makes you feel fulfilled. But not everything is great. And so there are some downsides. Again, talking to my 2 PhD team members, not having a grants office, really big issue. So when we have gotten grants, we've had to do everything. Not as much fun if you don't have someone helping you. We also, for that though, we do rely on collaborations. So we found a way around it. It's just, it just makes it harder. And we also don't have access to a library. So we make it work, or we go to a local university. I also have to work to maintain relative research independence with my team's work. I'm really strong, I'm a strong, opinionated individual, I've been told, and so I can maintain that, but for some it can be challenging. But what does that mean for those who are looking at health workforce research opportunities? Most associations and certifying bodies that I work with have PhDs or very experienced researchers leading the teams. So I really think that we are the sleepers of the health workforce research world. And with that, Janet, I'm going to send it back over to you.
Okay, thank you. Clark, would you like to share your journey?
Yeah, thank you. It's an honor to be here. I can echo some of Noelle's experience. Really, so I'm the health workforce consulting director for a company called Global Data. My team runs a health workforce microsimulation model for the federal government, the AAMC, and many state hospital associations and state and national professional associations. We actually get data on PAs from Noelle's team. So the modeling we do compares health workforce supply growth trends to health workforce utilization trends under different workforce growth scenarios, such as status quo, increased entrance to a given profession, or delayed retirement. We also look at the varying healthcare use patterns in the population, such as if all people were to access care at rates similar to those with the lowest barriers to care in terms of access, insurance, and affordability. And so these scenarios are an exploration of how the demand for health workforce would change with substantial progress towards national goals for health equity in healthcare. So that sounds really big and complicated, and I've only been here for a month, so I'm still learning about that, and there's a lot to learn. But where I started was I actually started as an AmeriCorps program member working for a homeless healthcare clinic here in Salt Lake City called the 4th Street Clinic way back in 2002 during the Salt Lake City Winter Olympics. And so from there, I learned how a clinic worked, and I saw how healthcare services were paid for. And I moved on to be a grant writer for a homeless shelter, and then put myself through grad school to get a master's in public administration while working as a respite care provider and as a welfare benefit and Medicaid analyst in the Utah state government. So in grad school, I studied policy analysis and program evaluation. I took all of the quantitative analysis and research design courses I could get. I found I really had a huge passion for data analysis. And so out of grad school, I was hired in 2010 by a group called the Utah Medical Education Council to do surveys of our state's health workforce. And so my first projects were surveys of the state's APRN and PA workforce. And over 12 years, I ended up surveying most of the licensed health professionals in Utah multiple times. And I ran these surveys and analyzed the data and started to put together a picture of how this analysis was being used to inform state legislators and educators and program administrators and to support health service researchers. And so through getting involved with Academy Health and the National Forum for State Nursing Workforce Centers, I kind of grew my network and began to understand more how I could improve analytical work and contribute more to the national conversations going on at the intersection of health workforce policy and technology. And that's really where I've developed my focus. In 2017, because my employer was willing to pay for it, I decided to get an MBA. And in that program, I focused on learning more about data modeling and information systems. And so since then, my work is focused on improving data quality and access to data through engaging in the policy process and making change in state governments, and then applying my subject matter expertise in this area to developing improved analytical tools from the available data sources to better describe the health workforce. So that's kind of where I'm at, and have come full circle to now being able to take that understanding and apply it in the consulting world to working with these state hospital associations and national entities that are measuring this.
Hey, thanks, Clark. And last but by no means least, Lorinda.
Hey, I probably should say it's Combs, not Coombs, before it gets too imprinted on folks' mind. I am the representative from the traditional tenure track kind of academic setting. I'm an assistant professor with a dual appointment at the Lineberger Comprehensive Cancer Center and the School of Nursing. And I've been at UNC Chapel Hill for just over 2 years. And actually, as I was listening to everybody talk, I was reflecting on the irony that I'm part of a workforce group, because I grew up in a remote rural area of northern Michigan, and I'm one of many children. And my first encounter with the lack of a well-distributed workforce came when I was 5, and we were running to this cat, to get to hold the dog, and I slipped and fell through our glass window, and there was no healthcare provider in my town, or even within a half an hour, 45 minutes area. So so my mom kind of butterfly stitched it. And that was kind of my first understanding of the importance of having good representation across the rural areas for folks. And I think that concept of social justice, I would call it, is really what's carved out my experience as a clinician and as a researcher. I'm a first generation bachelor's degree, first generation master's, and first generation PhD. So like anyone else who's stumbled into happy accidents, that's kind of been the story of my career. I went to undergrad at University of Michigan and joined a volunteer organization to work with social justice and domestic violence in Detroit for a year. So that was a very imprinting experience about and understanding the impact of social terms of health, also on healthcare, even though there were providers available, because of the insurance and the lack of access, people didn't get the care they needed. And that prompted me to go to nursing school. I went to San Francisco State University for a baccalaureate to master's degree in nursing. And then I started working with homeless HIV positive youth at that time in San Francisco. And decided I wanted to be an NP after a couple of years, went to UCLA, Eric, and where I did a VA honors traineeship, which was really fun, and worked as a nurse practitioner in a safety net hospital, San Francisco General, for about 7 or 8 years before deciding to get my PhD. And really, my story of workforce is around clinical, my experience as a clinician, really, and oncology as a nurse practitioner, caring for people, not really seeing representation in the research around advanced practice providers. So that was, I applied only one PhD program, UCSF, and that I got in. And fortunately, because I didn't really have a plan B, so my dissertation was using a large data set, administrative linked claims, the SEER, which is the surveillance, epidemiology, and end result data set linked with Medicare, to identify the contributions of nurse practitioners and physician assistants to cancer care for older adults. That was great. It was a great experience. I loved that. But after that, I got an opportunity. I looked around for postdocs and had a couple opportunities and really wanted to work in oncology. So University of Utah, which is how I knew some of the places that Clark was talking about, was where I did my postdoc. And it was part of a larger program to look at how specialty care is delivered. So acute level care called Huntsman at Home, which was right on time for the prepping for the pandemic was nurse practitioner provided acute level care in the home and looking at outcomes. And it was just a great experience with my mentor. And then I kind of pivoted a little bit after I did that to think about the value of mixed methods research. I've always been kind of a large data set person, and now I really see the value of mixed methods and qualitative. So I've been trying to integrate that with my current studies, which look at how you best provide care to older adults with metastatic cancer, essentially. So I'm going to try and cut that off so we can actually answer some of your questions, but sorry for us taking up so much of the time, but I think it's helpful to give context for all of our backgrounds. So it's a pleasure to be here with you all today.
This question, and this is for Clark and Noel, is to talk about your experiences in collaborating with researchers whose academic backgrounds are different from your own. So if each of you could think of one example where you've worked with somebody whose academic background is different. Hey, Clark, you want to start?
Oh, I have two, but I'll choose one. So I think my biggest example is back in 2016 through just talking with stakeholders in Utah. I began to meet with Dr. Mike McGill, who is an emeritus professor now of family medicine at the University of Utah. He's been very involved nationally and was long an administrator in the U of U health system. And he wanted to figure out how to calculate the workforce needs for primary care in the state of Utah. And he knew that I had access to the data and had some knowledge about it. And so we just started talking about what he wanted and kind of describing his use case. And I, had a significant amount of data modeling experience. And, we would meet each week and I would kind of bring an Excel spreadsheet and show him things I could calculate. And we just started, coming up with ideas, and he would feed off of my knowledge and I would feed off of his. And both of us have our subject matter areas that kind of overlap, but are very exclusive of each other as well. But it was just such a rich opportunity to learn from each other. And so over time, we won a few small grants and have built some modeling projects, and we continue to meet, even though he's retired now, just because it's interesting for both of us and we learn from each other. And we scrape together little things sometimes. But I would say even overwhelmingly, the product of our work hasn't been, a publication or even, massive amounts of money, but it's been just learning from each other and the commonalities we have and the areas we don't know what each other do. So.
Thanks, Clark. Noel?
Yeah. So I will say, first and foremost, collaboration is at the very foundation of pretty much all of the work I do, unless it's like a member satisfaction survey, which is irrelevant here. So it's very, very rare that we're not collaborating with someone. It's almost always clinicians. So it may be a clinician without research background, which is most often the case. Sometimes they have their doctorate, which is, great, but, my team brings particularly the stats and the nuance know-how. One of the projects that I think I'm really excited about right now is we're working with it's both PAs and a physician at a large New York academic medical center. They had approached us saying, we think that there's something in the workplace that can impact PA's intent to leave their employer. And we want to know more that can mediate the role, how the workforce factors mediate the role of burnout and that intent to leave. And as we started to go through, how are we already collecting this information? What is the best way to approach it? What we ended up doing was saying, let's look at burnout. Let's look at a composite score of data that we have been collecting for the past, 9 years, and we did it for 1 year. But, we looked at a composite score of feelings of workplace appreciation and feelings of having workplace opportunities. So do people feel appreciated? Do they have opportunities to grow? And does that make a difference in whether or not a PA feels has a sense of employer satisfaction. Intent to leave was a little bit dicey. That's now in a separate study. That's a large multi-site collaboration. And it does. And it's, it's something that I think intuitively, again, putting on my business hat when I was working in HR, it makes sense, right? That when you put in interventions, that should help. But there's not a lot out there, at least within the health workforce research, as of yet, that actually says, if you do X, Y, and Z, this will make the difference. And if it is done, it tends to be within an academic medical center, maybe multi-site, but still in one academic medical center versus us aggregating across, 3,000 PAs in the US. So we get those big sample sizes. And it's just been a really beautiful collaborative effort because they bring a lot of the nuance of being boots on the ground within their center. And some of the insights that come, particularly for the PAs, on what those workforce areas of opportunity, those things that are buffering them, they can provide those insights. So as we're drawing the conclusions, I think our conclusions are just tighter. I think intuitively, I know what's going to happen based on my background in business research, my background in clinical research, my background in psychology research. But clinicians know, right? And so I think those are really important. And I would highly recommend that anyone who does workforce research, if they are not coming from a clinical background, at least has someone that they can touch base with, because that is really important. Being able to talk to and consult with the professions that you're studying, because there are nuances that you as an outsider may not always understand. So that would be one of my big areas of collaboration in a current project that we are hopefully submitting by the end of the week.
I just want to add, I think I can't overemphasize the importance of just knowing how to build a team, because none of us know it all and none of us have enough time to do it all. And, for, short-term interns and research assistants are great, but if you can build relationships long-term with other disciplines who are working on common problems, then you all grow over time and you can accomplish much bigger things than if you're just focused on getting the next thing out the door.
Well said. Well, speaking of growth, for people completing doctoral programs, I think one question that often comes up is whether to pursue a postdoc or not. And I'd like Eric and Lorinda to share their perspectives because they've both completed postdocs. So you can choose who goes first.
I think that there's a really big component that needs to be acknowledged by a lot of academic places. The reason most people do a postdoc is to get a traditional faculty tenure track or some sort of faculty position. So they have a skill they need, or they need a topic they need to dive deeper into. And so as a clinician, I make jokes that I've worked my way down the pay scale as from a clinician to a researcher, because as a nurse practitioner in a specialty area of hematology oncology, and having worked across different systems like Stanford General or Kaiser, the idea of giving up that pay for a year or 2 years seems crazy. Like, I was like, why would somebody go for free labor? And for initially, I wasn't going to do a postdoc until I started kind of investigating what I wanted to do after, and saw that I needed to bridge my training in the doctoral program with what I wanted to do as a researcher in real life. So that bridge was important for me, but I actually don't think that it's a one size fits all scenario. I feel like it's really important to acknowledge that postdocs are not for everybody. And sometimes you can move right into a faculty position and your first couple of years essentially function as a postdoc. So I'll stop and let Eric speak to that.
Yeah, I echo. Lorinda is right. It's a paltry amount of money you get. I had a mentor tell me, well, you better do this now if you want to, because you'll be married and have kids later, and then you really will need the money, which I now realize now that I'm getting married next year. But anyway, I think that, first of all, one, postdocs in health services research are not so bad. Usually a lot of them are fellowships, so you are allowed to do what you want rather than you're being an employee of a PI like in biology or something. So they're not terrible in terms of flexibility, your ability to take courses, that kind of thing. The pay is bad, about 50K a year, usually, and they're time limited, usually 2 to 3 years. I will say for what I do, I'm like quasi sort of faculty independent researcher on soft money. In order to have won this grant, it's as long as an NIH grant, like roughly the size of like a K grant or something. Actually, it's longer because VA has longer page limits. But anyway, in order to have won this and to have submitted it 3 times, I had to have protected time to do this, right? So a postdoc was necessary for me. Was it good for my long-term earning potential? Probably not. But I think if you want a more traditional faculty position, especially one that's more focused on teaching or clinical duties, you probably don't have to do this. If you want to be funded on soft money out of the gate, you probably do. I mean, at least everyone that I know who has won a K or an R, and maybe I'm wrong here, has done the postdoc. So it is a bit of a hit for 2 years, but it seems sort of essential to me.
Can I just tell for folks who are listening who don't know the alphabet soup, the Career Development Award, the K is traditionally for somebody who's finished their PhD and is also in their postdoc or about to be done with it. The R is a higher level and much more difficult to get, but you get scored better if you're an early investigator. So there's pros and cons for going after one alphabet type or the other, but most people would not try to go for a R01 or R23 or anything like that until they tried for a K.
Yeah, and then winning a K, or at least writing a K, gives you the experience to know what to do for a larger grant. So it's all sort of incremental, postdoc, you learn how to write your first baby grant. Then I guess, when Career Development Award, you learn how to write a larger grant, et cetera, et cetera, et cetera.
Yeah, great. Well, thank you so much, Eric and Lorinda. So another question that I think people completing doctoral programs and postdocs, often struggle with is whether to pursue opportunities in academia versus not academia. Now, some folks, and Noelle, your example is somebody you kind of figured out fairly early on, academia was not where you wanted to go, but I think a lot of people are less certain. I don't know if, I guess we could all answer, but maybe Lorinda and Noelle or Eric, any thoughts you have on the pros and cons of going the academic route versus the non-academic route first? I think, Noelle, I know you have some observations, maybe, I'm going to summarize briefly some of what you talked about earlier with the folks you work with.
It's really important to think about what you want to do, like what makes you feel fulfilled, right? And if you go into academia or not into academia, and you discover that that isn't right for you, it's okay to get off the path and do something else. No one says that you have to stay where you are. So first and foremost, I think that's really, really important. For me, there were really 4 things that were my deal breakers. The process of tenure looked absolutely not for me. The pressure for funding my salary, the university politics, and work-life balance. Now, that could have been where I was in school. Like, I get that could be situational dependent, but I was aware that those are things that having a good balance was important to me. So being able to turn off my computer at 5 or 6 o'clock, really, really important. Being able to take my leave without worrying about it. Not having to find funding. I've never had a job in 22 years that I had to be funded for. They just pay me my salary, they grow my team, and they provide what I want. It's amazing. And I don't have to worry about tenure. My job is my job. The career ladder is relatively limited because there are only so many research jobs out there. So it does take time, but to me, it's a more casual path. But for me, that's right, because I don't have that drive to be in academia. For others, I have friends who love it because it's right for them. But more importantly, think about what you want to do. And if you need to change, it's okay.
Yeah, so I got my PhD at RAND, which is also a federal contractor, if people are not aware. But So I don't work there full time anymore. I do some part-time stuff, but full-time researchers there primarily work on federal contracts. There are some grants as well. So my decision not to go for that was, I wanted to direct my own research, and I didn't mind grant writing, etc. But if you don't want to do all this grant writing and stuff, working for a big contractor like that, you can still sort of be a PI project leader. I mean, your demands are more driven by client needs, but it's the same sort of science, right? So I have some colleagues that end up going back to Rand. I mean, they pay you more also. I think it's easier to win contracts than it is to win grants. I will plug the VA for one thing, though. The interesting thing about the VA mechanism for their awards is that they're not limited by cost caps like NIH awards. So for instance, for the CDA that I won, if I was a physician, say if I was a specialist, which I'm not, and I made $400K a year, they would pay you all of that. I think the K award's only $75K a year, right? So the VA awards are very competitive, especially for clinicians, including nurses and nurse practitioners, because they'll just pay you whatever your costs are. But you are working for the government, so that's another issue to consider.
So
Loretta?
I'll make the comment. I'm in the incredible position of advocating for a tenure track faculty position, which is funny to me because I'd never envisioned this as my path. So what I would say is when you're thinking about an academic position, there is a tenure track and then there's a clinical or fixed term. So those are both also very viable for people who want to do more teaching and also have clinical work, and the tenure track is traditionally for more research focused faculty. So the things that I would say that are assets for traditional tenure track, one especially affiliated with the National Comprehensive Cancer Center for me, is access to mentoring and mentorship around either disease specialty areas or bridging across multidisciplinary teams like nutritionists. If your idea for your your research award is going to involve multiple levels of intervention, it's great to partner with people who have specialty across that area. And that also makes you more, for those of you who are nurses or nurse practitioners listening, that makes you really important because a lot of teams are very physician heavy. And when you go to submit to the NIH, they'd like to see diversity of professional backgrounds. So I think that's one thing. The other thing is resources to kind of begin your process. Often you'll need pilot data, and it's very easy to tap into intramural opportunities where you can get funded to do that initial pilot data and then build it towards a larger grant. There's also infrastructure around like an infrastructure, like a KL2, which is an internal kind of mechanism for a career award, or help with supporting and putting out the door your grant, or with statistics. If you have expertise in like large data set quantitative SAS, but need help with mixed methods or qualitative analysis, there's a lot more of a quick plug-in of resources across academic centers. And I think those are made available for tenure track folk because they want to keep you, because they know you're not there for the big money.
Okay, great. Well, I think we've got questions in the chat now. One question I think that has been answered by Clark and Noel, but I'll just maybe read it out. And one of our participants asked whether you have to be have a PhD to shift your career path to workforce research. And this person has a doctorate of nursing practice, and has been working on research integrating DMP prepared nurses into managed care. And so both Clark and Noel said that they didn't think it was necessary to get a PhD to do this work, and they noted their own collaborations. I think Noel points out it might be a little harder or slower path, and so and I guess I would tend to agree. So I don't think it's necessary. But I do think if you have, say, a DNP or a doctorate that's more clinical, partnering with people who have a PhD can be very, very useful and important. Our second question, Clark is typing an answer, but we can also chat. is, does anyone on the panel teach courses in workforce, in workforce assessment development? And if you can provide any details. So Clark, maybe you want to share what you wrote orally?
Yeah, I'm invited to lecture by nursing programs and the medical school here in Utah, usually on an annual basis. I'll come in and give 1 or 2 lectures, but it's never been a full course. There's probably some out there that exist. I'm not aware of any that I've come in contact with. I think given what I know now, I probably could create a course like that and really focus on the methods of projection and the data sources and why we do what we do and how we know what we know. But I don't know. I don't think I'd love to hear what the others have in terms of knowledge of experience of this.
Noelle or Lorinda, if you want to share orally as well as putting in the chat in the Q&A forum.
I don't know of any courses, at least at UCLA. There's an organizational behavioral course for grad students, but workforce research is so niche. I'm not sure
Mm-hmm.
where it would be offered. I learned about this stuff at the postdoc levels.
Mm-hmm.
Did you want to say anything, Noel?
Yeah, I was just going to say that hearkening back to my work when I was working in human resource management, one of the things I studied was what are the kind of those core competencies, and then doing an assessment of all the different, HR generalist programs in the country, and, kind of matching it up. And some of those courses are likely to come from the business or HR world. It's not going to come from workforce. It's not necessarily going to come from a policy program. It's not going to come from necessarily any kind of healthcare workforce program. You're probably going to have to go to a business or an HR type program to at least get the tenets of it. And then you can tailor it to exactly what you're trying to study. But they'll give you, I think, the core skills that you need to execute it.
Great. Thanks, Noelle. So next question. Are there any conferences that any of you recommend attending as a PhD student for health workforce research? And so, yes, Academy Health, certainly. Please come to the Health Workforce Interest Group session and to the workforce themed call for abstract sessions, but other conferences that our panelists regularly attend.
Well, I want to expand on that because
okay.
As a clinician, I've been to a lot of disease specific, like American Society of Clinical Oncology, ASCO, ASH, Oncology Nursing Society, APSHO, but one thing that I have found that is really unique to Academy Health, which is why I'm still involved, is first of all, people are really nice. There's not a lot of attitude, and maybe that's because there's not a lot of people doing it, but there's a big conference, so a lot of people are coming. But even people who might be arrogant in another setting, like read specialists that I've interacted with in other environments, there's something about the expectation at Academy Health are going to be civil, and there's going to be discourse that's very data-based. And it's just, I would really, it was the first conference I ever went to. I was like, wow, this is really fun. This isn't stressful. I'm learning and I'm presenting, but it's really nice. So I think that's worth saying, because I was a PhD student when I went, and it was, it can be very stressful because you feel like you're on and you're auditioning. And if you say anything dumb, everyone's going to look at you and be like, oh, you'll never have a career. And so there's a lot of stress. So I want to just plug that, because I feel like, and also you can always come up to any of us and be like, hey, I saw you on the panel. Can we chat a little more? Because that's the other part of it, is there's a very warm kind of casual culture where you can just chat with somebody, and you can go up to someone who seems kind of famous and be like, hey, I had a question about your methods, and they'll just sit and talk to you. It's lovely.
Well, thank you, Lorinda. I'm really, I think that's true. I'm really proud to know that we cultivate that Academy Health cultivates it, and I think especially our interest group. Eric, Noelle, Clark, other conferences you attend regularly?
Yeah, so workforce research is becoming more of its own thing, but traditionally it's been kind of siloed in the disciplines that it's about. So I primarily work on primary care. So I go to the Society for General Internal Medicine, and there, there's a subset of people who work on workforce and primary care. So I would recommend you go to whatever the main conference is for your area, for your discipline.
Mm-hmm.
Yeah, I agree. As I started this work and started looking at what was out there to copy and inform my work, I found some of these smaller conferences. I think the first one I came to was probably the AAMC Health Workforce Conference. Academy Health is certainly great, has a lot of health policy conferences, but it's huge, right? And health workforce is only a small sliver of that. The other one I would really encourage, especially for anybody involved in nursing workforce issues, is the National Forum for State Nursing Workforce Centers has an annual conference, and that's all about nursing workforce issues.
Rather than adding on to the ones that I already mentioned, a few others that haven't been mentioned is I have had really great experiences with the American Public Health Association, APHA, to some degree to share knowledge so that can be implemented and to start to develop more collaboration. So it's less about developing my skills and more about that professional networking and information sharing. Similarly, one of my team members comes to us with a communication PhD. And he brought up a really brilliant point. And the areas that we're starting to move into now when we're looking at conferences and it's on our schedule are communication group conferences, because one of the areas that we're really interested in is looking at team dynamics, right? Our profession is a team-based profession, but no one really understands teams. And we certainly, as health workforce research, I certainly don't fully understand it, but you know who does? Communication experts are doing that research. IO, organizational psych people are doing the research. So who we need to be collaborating with are these other professions outside of our silos. And so that to me is our new realm. And we're doing it to develop our collaborations, to learn about things that we may learn about outside of our standard journals, but also to do information sharing as well. And in time we'll start presenting, but for now it's really about developing our skills and developing those networks.
Thanks. One of our participants asked about the name of the conference. Noelle, could you drop that? I don't know if you could put that in the Q&A forum. Yeah.
We are still working on which ones we're going to go to.
Oh, okay.
So there are some really big ones. I couldn't tell you off the top of my head which one my colleague Sean attends, that he used to attend as a communication PhD when he was in academia. But there are both the big APA meeting, and then there are some smaller IO meetings that I'm sure that we're going to put on our radar. And then the other one is American Public Health Association. Yeah.
Academy of Management is the big management.
Right. That's another one.
Yeah.
I think those are all good conferences. One other one that I know some of our folks go to is NAPCRG, which is the North American Primary Care, and I won't break it all the letters, but it's really, I think, largely family medicine. But what I think is neat about it is it intentionally includes folks from both the United States and Canada. So it's a great opportunity to learn to what some Canadian researchers are up to, and kind of some of the similarities and differences in how services are organized and paid for, and training as well across the two countries.
There's also a small conference called OTHC, the Organizational Theory in Healthcare, I think.
Yes, that's a good one.
I'm going to make one plug for the Society of Medical Decision Making and International Society of Medical Decision Making. I think they're really good opportunities, and there's a lot of transdisciplinary work that goes on there as well.
Thank you, Miranda. Well, I think seeing no additional questions, I will turn our webinar back to David.
Yes, thank you, Janet. This was fascinating. I can think of my own experience about how I became a health workforce researcher. As like someone pointed out, there isn't exactly a degree in health workforce research. So there's so many different paths to it. So thank you, Janet. Thank you, Noelle, Clark, Eric, Lorinda. It was a wonderful event, I think, and I hope the audience enjoyed it.